Great. Well, thank you everyone for the opportunity to talk about scaling up health innovations, but also assessing their readiness for scale up across systems. And I'll be just talking about some of the basic concepts about scalability and talking about some definitions and looking at the broader literature around scalability assessment. And then I'll hand over to Karen to talk to us about some of the practical steps that one takes when one wants to do a scalability assessment, and talk a little bit about how the ISET's currently being used and what some of our future research directions are. And then we'll have the opportunity to ask questions at the end. So why is scale up important? Well, the lag between evidence generation and implementation at scale is a considerable impediment to health improvement because it essentially denies or delays the community's access to effective services. So if we do see a large evidence practice gap, there's a whole bunch of really highly effective interventions that are not really being implemented across systems. And obviously, people are not deriving the health outcomes from those. Just to highlight this challenge a bit more closely, and this is an example from healthcare, Braithwaite and colleagues talk about the 60-30-10 challenge in healthcare. And this is a series of studies that Braithwaite and colleagues have done in the United Kingdom, Australia, and Canada. And they've done this over a number of years and done it across a whole bunch of different areas in terms of general practice. They've done it in care track kids. They've done it and remarkably and really interestingly, despite a lot of the efforts to close that evidence practice gap, we still consistently see quite a large gap. So their assessment, and this is fairly consistent over time, is about 60% of care that people receive is evidence-based. About 30% is low to no value care, and 10% is actually harmful. And if you look at the work by Emmons and Colbitz as well, they also highlight the fact that in the past 2 decades, it's been estimated that more than half of all cancers could have been prevented by applying knowledge that we already have. And this is not necessarily all of the new discovery sciences and interventions, just taking those highly effective interventions that we know are there and applying them across systems could have more than halved the number of cancers, which is a pretty powerful thought and highlights the importance of scaling up interventions. So what is scaling up? So scaling up is deliberate efforts to increase the impact of successfully tested interventions so as to benefit more people and foster policy and program development on a lasting basis. And this is the WHO definition. There's a couple of important elements, which include the fact that these are deliberate efforts. We're not going out there and just doing research and expecting it to be taken up. These are often efforts by large organisations. They could be governments, they could be large philanthropic organisations, but these are deliberate efforts. The other element of that definition that's quite important is that it's testing interventions so as to benefit more people, and it has an element of a focus on a lasting basis, sustainability. So what's the difference between implementation science and scale-up? And Karen has led a fantastic paper which I've been part of, which sort of talks about the history of scale-up and implementation science. Scale-up has come from population health, and most of the examples of effective scale-up internationally are from population health. And implementation science has really come from evidence-based medicine, but they are complementary. And I really see now how the fields have evolved, that implementation science is the broader concept and scale up is one part of it, which you can implement without scaling up, but you can't scale up without implementing. So the scale up process, what do we know about it? Well, we know that scale up can be non-linear and more often is, and it's inherently complex and very political. And we need to be very clear about what we are scaling up with our intent to do that. So Brown talks about the 7 Ps, which are programs, practices, procedures, policies, products, pills, and principles. But there are also other things that can be scaled up as well. They can be technology, they can be regulation, they can be plan management methods. And often when we are scaling up things within complex systems, we use multiple of those Ps. And the reality is, in the real world, when we are scaling up, that research evidence is only one form of information that informs scale-up processes for a number of reasons, because the inherent political nature of scale-up, but also the fact that often evidence doesn't exist about how to implement things at scale. And we have to factor in things like public opinion, stakeholder interests, expert opinion, politics of the day, economics, and the legislative and policy infrastructure. So if we are to think about scale up in more of a research frame, this is the New South Wales Translational Research Grant Scheme framework. The types of research that really inform scale up are along a continuum, and it starts with generating great ideas. Then we begin to sort of test things in some basic feasibility studies or pilots. We then move on to efficacy studies. We then replicate and adapt those studies to different contexts and different target groups. Then we do effectiveness studies where an intervention is tested under real-world conditions within a health system. And then scalability, which is how that innovation can be integrated into the wider health system. And then we move into monitoring. So this is a research frame. And as you can see, scalability is kind of at the end of that continuum, just before things are adopted across systems. This is another way of thinking about scale up, and it's more of a policymaker perspective. It's about, when we begin to pilot and advocate and begin to implement something, it might be across one or several districts. As we begin to expand things, it might be many, but not the majority of districts. And then we would sort of at mature expansion, when we are looking at scaling things up, it would be across most districts. But what this kind of has a bit of a picture of, but not a total picture of, is the reach, but we also need to look at adoption. So if we do think about scale up across a continuum, there are two critical concepts, the first of which is reach. So often when you'll go to conferences and you'll hear people talk about scale up, and they're saying that they've scaled up an intervention from 10 schools to 30 schools. And that's correct. They've taken that intervention and increased its reach. But when we really need to think about reach, we need to think about reach in a particular way, and that is the absolute number and proportion of individuals from a target group who are willing to participate in a given intervention or initiative. So this really gives us a denominator and numerator. So for example, we may want to implement something across the whole district. If it's only in 3 of 10 hospitals, well, that hasn't reached its full potential for reach. The other concept which is critical is that of adoption, which is the absolute number and proportion of settings of staff willing to implement an intervention. So really, effective scale-up is a function of reach and adoption across systems. And the goal to really, as I talked about previously, close that evidence practice gap and get the best outcomes for our populations, we need to implement those evidence-based practices across whole systems to ultimately result in higher health impacts. So sort of taking that basic framework that we talked about before, Devon Indig, Karen and myself, and Adrian Bowman, and Anne Brunswick did a bit of a study on pathways to scaling up health interventions. And what we did was we identified interventions through systematic review that had been scaled up, and then sort of backtracked them to see what their pathway to scale up was. And we identified 4 key typologies. The first, which was a comprehensive approach, which is the more traditional research approach that you would expect, which started off with development, then to efficacy testing, then tested in the real world, and then disseminated at scale. We had efficacy emitters, which jumped straight from development of a promising concept to a real-world trial to dissemination. The third type was trial emitters, jumping from development to efficacy testing, then straight to dissemination. And the fourth and most concerning was that of at-scale dissemination. Essentially, we couldn't find any discernible evidence that informed that. Now, I won't sort of ask everyone to think about that, but in your own minds, think about which would be the most common pathway, and I'll give you an answer shortly. The answers are, the most common pathway was the type 1, which is fantastic, but that in large part, I expect, was an artifact of the fact that all of these things were in the peer-reviewed literature initially. So it really does miss a lot of the real-world scale-up that is done out there in the policy world where it's not published in the peer-reviewed literature. 15% concerningly was based on low discernible evidence. And the other area that is a bit concerning is that only 25% of the studies were what we call trial emitters. They jump straight from efficacy to dissemination. And I'll talk to you about why that's an important concept. So there's something that we found in the literature across a whole range of areas, particularly in chronic disease prevention, is the scale-up penalty. So this is a systematic review done by Sam Crabb from the University of Newcastle that I was involved with Adrian and Philip Wolfenden. And it found that across the measures of weight, status, physical activity, and sedentary behaviour, that the effects reported in these studies when they were scaled up were typically 75% or less of the effects of pre-scale up efficacy trials. So that's quite a lot of erosion in the effect size of intervention. So this is a real concern. So when we go back and look at those trial emitters and you combine those with the no efficacy testing, there's a lot of uncertainty there where people are potentially spending millions to billions of dollars on things that may ultimately not be effective when they're implemented at scale. So the important message here is that really effective scale-up does require action at multiple levels. It includes the individual and patient level, provider and team level, organisation, system, and community level. And that's what the broader literature tells us when we want to effectively scale things up across systems, that's what's required. And there's a change in focus as interventions are implemented at scale. Often when we're implementing things on an efficacy trial or a pilot, we have quite controlled delivery. As we implement things across whole systems, we have less control of its delivery. It'll be implemented using the resource profiles across different contexts and settings. Often there's a focus on efficacy when we're implementing things at a small scale. When we implement things across whole systems, we can't establish the efficacy of everything that's occurring. We need to establish monitoring systems to see how interventions are implemented across whole systems. Often at a small scale, things, there are bi-directional relationships. When we implement at a system level, these are dynamic relationships with complex stakeholder relationships, many people collaborating or not collaborating to achieve these objectives. Often we're also talking about, at a small scale, individual capacities of highly motivated people that are really interested in implementing intervention. However, when we look at implementing things on a system level, we have to look at things on the basis of organisational culture and capacity. And we need to actually build strategies in place that will take not only those that are highly motivated to make change, but also those that are, maybe ambivalent about change, but will do it with a bit of support, and those that are actively fighting change. So you need to deal with all of those sort of scenarios in terms of building the capacity to implement change across systems. So what are some of the scale-up frameworks out there? Well, there's a growing proliferation of those, and a study by Franz Legare and others, and a systematic review, which I had the pleasure of being part of, showed that there's just an exponential number of these, and they're growing. And the most commonly cited one is the WHO ExpandNet framework, but I also developed a framework for New South Wales Health that you may be interested in as well, which is a lot shorter than ExpandNet. So what would some of the key characteristics, given there are so many frameworks, what are some of the common features of these frameworks? The first is the importance of conducting some form of scalability assessment. It's not always called that, but essentially looking at selecting the right intervention. And I'd always say that it has to be an evidence-based intervention. That'd be my first take-home message from this. Another common feature is building a case for change and developing a scale-up plan with your key stakeholders. Also, the importance of understanding the context and really establishing those preconditions for scale-up. Thinking about how you have to realign and mobilise resources to support that scale-up implementation. It may be having to retool and retrain existing staff. It may be having to create a new workforce. But you need to sort of systematically think through those and look at the resource implications of those different potential pathways for scale-up. Then it's critical to drive change using data and monitoring performance. Certainly the most successful examples of scale-up, and I won't be talking about those today, but some of those in healthcare, but also in population health. This is a critical factor where you monitor change, where it can be monitored at a system level, but also at the level of practitioners. So they're getting feedback on how they're performing and comparing to other areas, but also decision makers can get information, and that helps to maintain political will. And another critical factor is coordinating governance. You can't leave these things to themselves. They need to have tight governance and information flows up and down from the practice level all the way up to decision makers. So what are some of the conceptual frameworks that have been used? As I said, the most commonly applied framework, and this is a study by the Global Alliance of Chronic Diseases. They funded a whole bunch of scale-up studies, and these are some of the frameworks that have been used to support scale-up efforts. They can include the REAIM framework, the consolidated framework for implementation research, ExpandNet, and the MRC complex intervention frameworks. So what is scalability? So scalability is the ability of a health intervention shown to be efficacious on a small scale or under controlled conditions to be expanded under real world conditions to reach a greater proportion of the eligible population while retaining its effectiveness. Now that's a mouthful, but it has some critical elements that I'd like to sort of leave with you. So it's a characteristic of an intervention. So it's whether, and it should be efficacious on a small scale, and under those controlled conditions, and there should be an attempt to expand it under real world conditions. And you need to measure the reach and look at the eligible population and attempt to retain its effectiveness. So there's some critical elements of that intervention. So why is assessing scalability important? Well, it's a critical question. Are interventions suitable for scale up? And in the absence of any formal scientific process to do scalability assessment, certainly anecdotally, my experience as a policymaker for 25 years is that people will go in with their best bet or the best available evidence or hunches or a feeling. So action needs to happen. And when governments need to do something, they will, of course, try to be evidence-based wherever they can be, but where there isn't evidence, sometimes they will just go with hunches. So what scalability assessment is critical for is to inform those decisions using evidence. You need to also identify the factors that may help or hinder scale up, and that's what a scalability assessment can help you do. And it also asks the fundamental question, who should be involved in that process, which is critical for the planning in the next step. So there are lots of scalability assessment tools, and one of those is a tool that has been developed by myself and Karen. It's the Intervention Scalability Assessment Tool, and some information is there on it. It's also been translated into French by the WHO, and it's available on the Australian Prevention Partnership Centre website and the New South Wales website. So it's designed to assist making assessments of scalability of an intervention, identifying these contextual factors that may help or hinder scale up, determining how the design of a program or intervention could look like when you're looking at it. And it can be used as a comparison tool, as Karen will show us. And it's generally completed through a group consensus process, but that can also be done through surveys. So it has a couple of key elements. The first part is really looking at the existing evidence and defining the problem. Look at your epidemiology. What is the shape and size of the problem? Who's affected by it most? And really defining the potential solution that you could put in place to impact on that problem. This is where it's critical to talk about the intervention and really build a strong case of what that intervention looks like. Thinking about the strategic context and alignment with existing strategies, then really having very clear evidence wherever possible on the effectiveness and efficacy. Ideally, if you had that pathway that we saw earlier in the presentation, but often you don't have that, but having a very clear understanding of that evidence, and then where possible, looking at the costs and acceptability. The other areas, which is part B of the scalability assessment, is the implementation planning, where we take a bit of the expert opinion, the evidence that's there, and we talk about, what would an intervention look like? What would the fidelity and adaptation need to look like? What are core components of an intervention? What can be adapted to context? What is the reach that we want to achieve, and how acceptable would that approach to achieving that reach be? Thinking about the delivery settings and workforce. It may have started off an intervention, may be using a highly expensive workforce like physiotherapists, but you might want to use fitness leaders, which are easier to train and cheaper workforce, for example. You need to think about the infrastructure and then ultimately how you sustain these interventions within systems. So I think that's where my presentation ends, and I'll hand over now to Karen. So I'll stop sharing and I'll over to you, Karen.
Thanks, Andrew. Okay, I'm just going to get my slides up. Just bear with me while I share. Okay, I hope my slides are visible. Excellent. Okay, so thank you so much, Andrew, for setting the scene. And now in this section, I'm actually going to take you through the tool that he mentioned, and I suppose a bit of a process as to, if you do decide to use it, how you might go about using it. And then I'll give some examples of how it has actually been used in the real world, and how it's also been adapted to suit their needs. So just to reiterate, I guess, as Andrew already alluded to, scale up is actually very rare. And if we do want to invest in scale up, we want to invest in the best possible intervention you have to scale up. And the ISAT will help you hopefully make those kinds of decisions. So you may already have an intervention that you think is suitable for scale up, or you may be in a fortunate position to pick from a number of interventions that you could consider scaling up. And either way, conducting a scalability assessment will be a useful process to help you identify some of those potential barriers that you may encounter. Okay, so if you do decide to use the ISAT, we do have a suggested process on the Australian Prevention Partnership Centre website, and the link and the QR code is there for you to have a look at it. But I will now take you through this process briefly. Okay, so as I mentioned, this process is very much a suggestion, so you can adapt it as you see fit and whatever meets the needs of your groups. And there are 3 proposed phases, and within these phases, there are some steps as well along the way. And I will now take you through some of these steps in more detail. Okay, so phase 1 is what we call the preparation phase, and this is the pre-work part of the ISAT process. So if you are considering several interventions for scale up, it is possible that you might want to do the ISAT for each of those interventions. It really depends on what your goals and your aims are. But to complete the ISAT, it does require some resources to manage the process, as well as to take ownership of its documentation and completion. So we do recommend it is best that at least a team or one individual is in charge of driving this process. And secondly, you may want to assemble a second team or a group that will be part of the assessment and discussion phase. That second group may already be existing in the form of a steering committee or some kind of governance committee that oversees the intervention. And you might want to tap into that. So definitely you don't have to reinvent the wheel. But one consideration though, and as Andrew mentioned, the ISAT does cover a range of domains, from understanding the strategic and political landscape to understanding the workforce and infrastructure requirements required at scale up. So it is good to have a representation from a broad range of stakeholders. People like, policymakers, implementers, local health promotion representatives, delivery organizations, or even maybe consumers of the target population that you might be addressing in your intervention. And it is possible to have a smaller number of stakeholders, but just be wary that it might limit the range and variability of perspectives that you get. That's sort of what really enriches this process. Okay, so the second step under phase 1 is to start filling out the ISAT. So if you do go to the ISAT, you'll see that there is a number of questions in the ISAT that you need to answer, and then you can complete as many of those questions as possible. And that's why I sort of said it's good to nominate someone to drive this process, because, and there could be someone like the program manager that has ready access and knowledge of the intervention. It's a bit easier to fill it out. So pre-filling the information is helpful, and then you would then distribute the ISAT to the stakeholders and invite them to make comments and corrections, or even ask them to help you fill in any gaps if you couldn't find all the information straight away. And then based on the draft ISAT that they're receiving, they can start thinking about some of those assessment domains and the readiness questions that we have in the ISAT, and they can start scoring those domain questions. And then you could then use that meeting, which will happen subsequently, to then discuss some of those scores. Okay, so phase 2 is the assessment phase, and we believe this is what makes the ISAT really quite novel and necessary. This is the opportunity for everyone to engage in meaningful dialogue about the different aspects of the scalability of the intervention. So the purpose of this phase really is to reach agreement on the scoring of the scalability of the intervention. And while we do think, it would be ideal to have face-to-face discussions, we understand that, in today, it's, very common to now have online meetings, and that's totally fine as well. And as you will see in one of the examples that I will present later, some groups have been quite innovative in how they actually try to engage people in this assessment process. You may hold one meeting or more, depending on what's required and how long those meetings are for. And there's no prescribed time frame for each session. It really depends on availability of your stakeholders. So at the first meeting, hopefully all the stakeholders that are involved in the process will have received a pre-filled ISAT. So And if they have scored those different domains already, you can collate those scores and then use this opportunity to discuss any variations in scores and then come to some kind of agreement. If they haven't, then you would use this time to then start assigning scores and agreeing and making recommendations on the scalability of the intervention. And of course, have another discussion or meeting if necessary. And finally, after all that's been done, the phase 3 is the reporting phase. It will be good to collate the results and complete the reporting. There are templates in the actual ISAT to help you with this. Attachment A, for example, is a short report template, which will help you summarize some of the key findings and the key discussion points that you have gathered through the process. And it is recommended that you actually input the scores into this radar plot, and then that will generate this plot, and you can straight away see, I guess, where the strengths and weaknesses lie of your intervention when you are considering it for a scale up. Okay, so here is a link to some other supporting documentations, not specifically about scalability, but it does contain information about scalability, but it's also about scaling up interventions. Okay, so now we've talked about sort of the tool. I wanted to provide you with some examples of how the ISAT has actually been used in the real world, and give you some insights to how different teams have adapted the ISAT as well to suit their needs. So there was a scalability of a assessment of the community falls prevention intervention in Ireland, as well as evidence-based healthy eating and physical activity interventions in early childhood education and care, and also interventions targeting obesity prevention in infants. I will be focusing on the first two. Okay. So in 2020, not long after the ISAT was published, researchers in Ireland were really interested in assessing the potential scalability of a multi-component integrated falls prevention service for community dwelling older people. This service has actually been implemented in a small region since 2015. And essentially, their objectives were they wanted to see how scalable this intervention was, moving it from a regional to a national level on a phased basis. And because they were one of the first sort of research teams to use the ISAT, it was really a good opportunity for them to also reflect on the feasibility and the usefulness of applying the ISAT in the real world. I won't go into too much detail about the intervention. Hopefully, if you're interested, you can look for it in the literature. But essentially, this was a mixed method study containing of 4 key steps: document analysis, they did interviews with stakeholders, online survey, and opportunity for feedback. And what was actually really good about this study was they actually were very purposeful in selecting the key stakeholders that they chose to interview. One of the reasons was they wanted to identify people that had really in-depth knowledge of the delivery of the intervention to inform the potential scalability. So they spoke to people that were at the health service management level, geriatricians, service coordinators, and heads of disciplines in physiotherapy, occupational therapy, and nursing. So they were able to canvass quite a diverse range of stakeholder views. So where it's quite innovative was because they conducted this in sort of right in the thick of the COVID lockdown periods and restricted movements. Instead of holding those discussion meetings, particularly after they've had some interviews, they decided to actually translate the what would normally have happened in a discussion session into an online survey. So they made the readiness assessment questions into an online survey, and they asked the stakeholders to rank them, and also gave opportunity for them to have open-ended responses to some questions. And then they were then able to collate those in order to then form the final report. Okay, so the researchers were able to plot the scores on a radar plot to generate a visual representation of the results, as well as completed a summary of the findings. And as a final step, they actually conducted an online meeting where they presented the results back to the stakeholders that contributed to the process. Now, I won't go into too much detail about the results, but suffice to say that the research team were able to make an assessment on the scalability of the intervention. In fact, they concluded, based on the feedback, that the intervention was not quite ready for scale up. They identified through this process that were quite a number of implementation considerations that needed to be addressed before the intervention was ready for scale up. So specifically, they cited challenges related to the implementation infrastructure, things like the lack of adequate room space for assessment clinics, like some of the potential scale up sites. So while this wasn't necessarily the outcome that they were hoping for, what it did was it did help them identify those barriers that they would have encountered had they just straight gone to scale and not done this process. And if they had embarked on this process, they may have discovered halfway through that, they just couldn't do it and may have had to abandon it halfway. And as you can imagine, as Andrew said, it's millions of dollars when you invest in something like this. So you don't want to sort of start the process and have to, abandon it halfway. And as I mentioned, what was really good about this project, they also were able to identify some of the benefits of using the ISAT as well as some of the challenges that they faced. So in terms of benefits, they identified that this process was actually really systematic and transparent. And they found that they were able to canvass a diverse range of perceptions from different stakeholders, and it was really helpful. They found that doing the scalability assessment also gave them the ability to look at scalability more holistically and not to be guided by just one thing. And the various domains allowed them to consider the complex interplay of the different factors that they would have to consider when scaling something up. And what was also really pleasing was they found that the inclusion of the radar plot at the end was really useful in helping them communicate with the stakeholders. It provided them a visual sort of one-stop shop representation of the areas that needed to be strengthened or that required further discussion. Some of the challenges that they encountered as part of doing this process was, as I mentioned, there are a number of steps involved. So the time and the number of steps involved to require the ISAT, you do have to put some effort into it. And I guess that's why we recommend that you, if you are going to embark on something like this, you nominate someone to drive this process. They did find it, they found some difficulty in sourcing some information. Specifically, Andrew, interestingly, they identified effectiveness data was one of the gaps in the information. So that in and of itself, it's an important finding. And also, this is also why it's good to have a diverse range of stakeholders who may know something else that you don't know, and they can maybe help you fill those gaps. But again, they found it, they noted that maybe the ISAT was less useful for interventions with emerging or an unclear evidence base, which is in and of itself is a really important finding. So if you're struggling to fill in that part of the ISAT, then maybe you might want to reconsider whether the intervention is suitable for scale up as well. And then finally, they also did mention that potentially those people with less experience with scale up concepts or scalability concepts might find it a little bit tricky. Okay. So one more study that I'll go sort of go through that has used the ISAT, and again, they've used the ISAT a little bit differently as well, was a study looking at factors that influence the scalability of healthy eating and physical activity interventions from the perspective of early childhood education and care services. So again, different setting and different sort of group of stakeholders. So the researchers in this case wanted to describe from the perspective of early childhood center directors, what their perceptions were regarding the potential scalability of a variety of healthy eating and physical activity interventions, as well as they were looking at the associations between the perceived scalability of the interventions and service characteristics. Again, their methods were a little bit different, and because they wanted to survey a large number of early childhood setting directors, they actually converted the ISAT into a quantitative survey. Not entirely dissimilar to what the other group did, but they weren't just looking at one intervention, they were looking at a range of interventions. So they wanted the directors to score these interventions across 6 healthy eating interventions and 6 physical activity interventions. And to do that, they conducted a telephone survey, and they asked the directors to score those questions on a 5-point Likert scale. Now, please don't attempt to read this slide. It's purely here just to illustrate, so I guess, a summary of what they ended up finding. And as you can see on the left-hand side, the rows were the various physical activity interventions and the various healthy eating interventions. And across the different columns were all the scores for each of those domains relating to scalability, as you will find in the ISAT. And what they were able to generate was this, that for each of those interventions, they were able to generate radar plots so they could clearly see which ones of those interventions rated more highly than the other. Okay, so I hope that was a useful information on how others have used the ISAT before. It's really great that, we've also heard anecdotally from others that they've been using it. So I think there are a few more papers out there in the literature if you're interested. But we do know, and Andrew and myself are involved in a number of different projects now that are using the ISAT. So there's one about looking at the scalability of the opioid stewardship framework, men's mental health programs, oral health, and also we're now looking at how we can use the ISAT to actually inform interventions that are being tested in sort of the effectiveness sort of trial. And we do have some rather ambitious plans, Andrew, to for the ISAT as well going forward. We would love to do some psychometric testing to determine whether it's got measurement properties. And also we're quite keen to update the ISAT to be more prescriptive on equity considerations. And Andrew, I might let you take over now to conclude.
Sure, yeah, and thanks, Karen. Some really fantastic practical examples on how the ISAT's been applied. And the only other sort of point to make is that it has been used internally within New South Wales Health and other organisations, but they were for sort of internal decision-making processes. So I have applied it when I was working at the ministry on a couple of occasions. But obviously that hasn't been published in a peer-reviewed paper, and it's part of a confidential government process. So in conclusion, the implementation of those effective interventions that I talked about before are essential to improving health outcomes. And really the investigation of the optimal ways to expand programs continues to really receive inadequate attention. We want to see more examples of scale health interventions being published, but also scalability assessments. And really, Scale Up does require that, striking that right balance between adapting to that local context, maintaining core elements of teaching fidelity, and effective Scale Up does require systematic use of evidence in many forms that's importantly linked to that decision-making process. And that's what we sort of found in the broader literature, is these are critical elements. It doesn't always exist. And in many instances, as I said previously, through our observations, there isn't a lot of evidence used for scale-up processes, unfortunately. So I think, if you can take home the message, if you're going to scale something up, try to make sure it's evidence-based as you can. And don't go down the path of scaling up, multi-million dollar interventions unless you know it has some established efficacy at least. So thank you.